Okay, let's dive in. We've got this fascinating stack of notes right here, shared with us by you, our listener. They look like really solid revision material, very sharp, all about one topic, sleep paralysis.
Yeah, and it's a perfect topic for this kind of deep dive. It's specific, surprisingly common, and these notes give us a really clear structure to follow.
Right.
So our mission really is to take these notes,
Hmm.
the definitions, the causes, the risks, all of it, and kind of unpack them.
Turn them into something, easier to grasp.
Exactly. Make it clear, memorable, give you a solid understanding, whether you're actually revising or just want to know more.
Absolutely. Taking the raw info and finding the core story inside. So let's start right there. What is sleep paralysis? Fundamentally, these notes describe it as this temporary kind of unsettling state.
Right. The key thing, the most striking part, is that temporary inability to move or speak. It's not just feeling weak. You are literally frozen.
And this happens at a very specific time, doesn't it? Not just any time.
Yes, that's crucial. And the notes highlight it. It occurs during that transition, either when you're just nodding off or maybe more often when you're just waking up.
So the paradox that just jumps out is you feel awake, your mind's online, but your body's just not responding.
Precisely. You're conscious, you know where you are, but you're completely immobile. The notes really stress that combination. Consciousness plus paralysis. That's the defining feature.
Okay.
And often, it doesn't stop there. There are other pretty intense features that can come with it.
Like the hallucinations mentioned, what sort of things are we talking about?
Well, the notes specify they're usually visual or auditory.
Yeah.
So you might see figures or shadows or just hear strange sounds.
Wow.
And another really common one listed is that feeling of pressure on the chest. People often describe it like a heavy weight pushing down.
Okay. A weight on your chest, can't move, seeing or hearing things. Yeah, that sounds genuinely terrifying. How long does an episode like that typically last?
Thankfully, it's usually quite brief. The notes say seconds, maybe up to a few minutes.
Oh, okay. Not hours then.
No, not typically. And it can resolve just on its own, or sometimes, if someone touches you or makes a loud noise nearby, that external stimulus can actually snap you out of it.
Interesting. So an external nudge can sort of reset things.
It seems so,
Yeah.
sometimes. And the notes link this whole experience directly to REM sleep, rapid eye movement sleep.
Right.
Yeah, that connection is fundamental. It's key to understanding the mechanism, which I'm sure we'll get into. The notes also mention briefly how it's recognized across different cultures historically, often tied up in folklore, demons, spirits.
Which makes total sense, doesn't it? Given how
Yeah.
frightening the hallucinations and the feeling of being held down must be. Okay. So being awake but stuck, often with these vivid, scary sensations, that's the core definition we're working with.
That's it.
Now, moving from what it is
Mm.
to the really big question, why? Why does this happen? What do the notes say about the causes, the etiology?
Well, the notes are pretty upfront that it's not, fully understood.
Yeah.
There isn't one single definitive cause known. But the leading theory, the main driver they point to, involves disruptions in the normal sleep-wake cycle.
Disruptions, like the brain's timing gets messed up somehow.
Exactly. And the core concept behind that is what the notes call REM sleep intrusion.
Intrusion.
Yeah, basically elements of REM sleep things that should only be happening when you're fully in that REM stage. They kind of bleed over into wakefulness.
Ah, okay. So bits of the dream state are sort of leaking out while you're trying to wake up.
That's a good way to put it, yeah.
So what kind of things can disrupt the sleep-wake cycle enough to cause this REM intrusion? What factors are listed in the notes?
Several things seem to increase the risk. Sleep deprivation is a big one, just not getting enough sleep.
Makes sense.
Also having a really irregular sleep schedule, shift work, or just, very erratic bedtimes. High stress levels are mentioned too. And importantly, other underlying sleep disorders.
Like what?
Well, the notes specifically call out narcolepsy. It's a condition strongly associated with sleep paralysis.
Right, okay. So if your sleep is already kind of wobbly because of another disorder, this is more likely. Now, let's get into the how. How does this REM intrusion actually cause the paralysis and those weird sensations? This is where it gets really interesting, I think, the pathophysiology.
Yeah, this is fascinating. It really ties back to that REM sleep connection. See, during normal REM sleep, when we're having vivid dreams, our brain actually paralyzes our voluntary muscles. It sends out signals to inhibit them.
Why does it do that?
It's essentially a safety mechanism. It stops us from physically acting out our dreams. Imagine, dreaming you're running and actually starting to run in bed.
Ah, Right. So it's like your body's built-in safe mode for dreaming.
Exactly. That's a perfect analogy. Now, the notes explain that in sleep paralysis, this normal muscle inhibition, this atonia, it persists, it hangs around too long.
Even when your brain is waking up.
Precisely. So your brain starts becoming conscious, you start becoming aware, but that paralysis switch is still stuck on. You're awake, but your body is still in that dream acting prevention mode.
So your conscious mind is back online, but the part controlling movement is still sort of logged into REM sleep, still holding things down.
That's a great way of thinking about it, yeah. And the notes suggest the hallucinations and that chest pressure feeling. They're likely because your brain is in this really confusing transitional state,
Kind of caught between worlds.
sort of stuck between dreaming and wakefulness. So elements of the dream state, maybe dream imagery or sensations, spill over into your conscious perception.
Wow. Okay, the brain being caught between states. That really clarifies why it feels so strange and frightening. Right. So we know what it is and roughly how the mechanism seems to work. Now, who is more likely to experience this? What do the notes tell us about risk factors and how common it actually is, the epidemiology?
Okay, risk factors. The notes list several things that seem to increase your chances. We already mentioned a history of sleep disorders, particularly narcolepsy, but also things like insomnia.
Right.
Sleep deprivation, again, and having an irregular sleep pattern, those are major triggers.
Just things that mess with your sleep generally?
Pretty much, yeah. The notes also include family history of sleep paralysis.
Oh, interesting. So potentially a genetic link.
It suggests there might be some genetic predisposition for some individuals, yeah. And also, factors related to mental health and stress are cited. Things like high stress levels, anxiety, depression, or even past trauma.
Okay, so factors disrupting sleep, mental health links, maybe genetics. How common is it overall? Do the notes give us any figures like prevalence data?
Yes, they do. According to these specific notes, the prevalence in the UK is estimated at around 7.6% of the population.
7.6%. Wow, that feels higher than you might instinctively guess.
It's more common than many people think, yeah.
So that's, I mean, quite a few people potentially affected. And the notes mention demographics too, like age.
Yeah, they specifically state it's particularly common in adolescents and young adults.
That young adult group often has changing sleep patterns, more stress. Maybe that fits.
That could definitely be part of it. It seems to be a peak time for experiencing it.
Right, a specific window in life. Okay.
Okay.
So we've covered the mechanics and the who. Let's get back to the experience itself. What does it actually feel like if you're the one going through it? The clinical features, what are the key symptoms beyond just, not being able to move?
Well, the main symptom is the paralysis while being conscious, like we said. That's core. But the notes detail these accompanying features, which are often the most distressing part for people.
The hallucinations again.
Yeah, those hallucinations, visual, auditory, sometimes even feeling like someone's touching you or is in the room.
Yeah, that's chilling.
And that significant feeling of chest pressure we talked about, that sense of being weighed down or even finding it hard to breathe because of the pressure.
And the emotional side, it must be incredibly frightening.
Oh, absolutely. The notes mention a strong sense of fear or even impending doom is very common during an episode.
So you put all that together, you're stuck, you might be seeing or hearing things, feel like you can't breathe properly, and you feel utterly terrified.
It's understandably incredibly distressing.
Yeah, and if this happens repeatedly, what are the knock-on effects?
Well, the notes say these episodes can definitely lead to significant distress. They can make people anxious about sleeping, disrupt sleep patterns, and that can result in excessive daytime sleepiness and fatigue over time.
Yeah, sounds like a really negative cycle to get caught in. Now, what's fascinating here is, given some of those symptoms, like the paralysis and hallucinations, how do you know for sure it's sleep paralysis and not something else, maybe something more serious? What do the notes say about differentiating it, the differential diagnosis?
Right, this is important. Getting the full picture of the experience is key to telling it apart from other conditions. The notes list things you'd want to consider ruling out.
Such as
Narcolepsy, for one, especially if it involves cataplexy.
cataplexy being.
That's the sudden loss of muscle tone, often triggered by strong emotions, which is a hallmark of type 1 narcolepsy.
Okay, so rule out narcolepsy. What else?
Other sleep-related movement disorders are mentioned, like restless leg syndrome, although the feeling is usually quite different. Also, nocturnal seizures need consideration, as they can sometimes involve immobility or strange sensations during sleep transitions.
And what about things that aren't strictly sleep disorders, like causes of temporary paralysis?
Yeah, The notes broaden the differential there to include things like TIAs, transient ischemic attacks, or mini strokes, or certain neuromuscular disorders that could cause temporary weakness or paralysis.
Makes sense to consider those, but the key thing that points towards sleep paralysis, as the notes imply, is the context, right? Happening right as you fall asleep or wake up, and that specific cluster of symptoms.
Exactly. The timing, that hypnagogic or hypnopompic period, combined with conscious awareness during paralysis, and those common accompanying features like hallucinations. That whole picture is really characteristic and helps distinguish it.
Okay, so if someone is experiencing these symptoms and they go to their doctor, how is it typically investigated and managed, according to these notes? What happens next?
Well, the notes really emphasize that the diagnosis primarily relies on getting a detailed clinical history.
So mostly just talking it through, listening to the patient's description.
For the most part, yes. Hearing about those characteristic symptoms is usually enough for a diagnosis.
Are tests ever needed, like sleep studies?
They can be. Sleep studies, like polysomnography, may be used, but the notes are clear this isn't like standard practice for every case.
Okay. When would they be used then?
Typically, in some cases, maybe if the diagnosis isn't clear, or more often, to rule out an underlying sleep disorder, especially if narcolepsy is suspected, or perhaps to look for specific abnormalities in REM sleep patterns.
Ah, so the sleep study is often more about finding an underlying cause, like narcolepsy contributing to the sleep paralysis, rather than confirming the paralysis event itself.
Precisely. And the notes also add that things like neuroimaging brain scans or wider neurological workups are usually unnecessary unless there are other symptoms or signs pointing toward a different underlying medical condition.
Right. That's helpful. So it's not typically a huge battery of tests unless something else seems off. Okay, so once it's diagnosed, what's the management strategy? How do you actually treat it or reduce how often it happens?
The main focus for management, particularly as noted for the UK context in these notes, is really centered on two things: improving sleep hygiene and addressing any underlying sleep disorders if they exist.
Sleep hygiene comes up again. It seems so fundamental for so many sleep issues. What specific things are recommended?
Yeah, it really is key. The notes list things like maintaining a really regular sleep schedule, consistent bedtimes and wake times, even on weekends, if possible.
Tricky but important.
Definitely. Also, using relaxation techniques before bed, finding ways to reduce overall stress, and simply making sure you're not chronically sleep deprived. Those are the core strategies.
And treating underlying issues.
Right. The notes reiterate that point. If there is an underlying disorder, like narcolepsy, successfully managing that condition can directly help lessen the sleep paralysis episodes.
Okay. And what about medication? Is that part of the picture?
Sometimes, but usually not first line. The notes mention in their additional information section that if the episodes are really frequent or particularly distressing and significantly impacting someone's quality of life, then medication might be considered. They specifically mention clonazepam as one possibility, but that's typically after trying the lifestyle and sleep hygiene approaches thoroughly.
Got it.
And another important point the notes make is about education and reassurance. Just explain to someone what sleep paralysis is, that it's generally benign and not dangerous, can itself be really beneficial. It can reduce the fear associated with it.
That makes a huge amount of sense. Reducing the fear might even help break the cycle, potentially. Okay, finally then, what's the overall outlook? Is this something serious in the long run? What's the prognosis? And are there any potential downsides or complications to be aware of?
The notes are generally pretty reassuring on the prognosis front. It's described fundamentally as a benign condition.
Meaning not dangerous in itself.
Exactly. Importantly, it's not usually considered a sign of some serious underlying physical or neurological disease in most people who experience it.
That's definitely good news to hear. So it's not like a red flag for something worse lurking underneath.
Correct. In isolation, it's generally not. The notes say the episodes themselves are typically sporadic, they come and go, often infrequent, and they can even resolve on their own over time.
Okay.
And with those management strategies, we discuss better sleep hygiene, managing any underlying conditions. The frequency and the impact can often be significantly reduced. So yeah, overall the prognosis is generally favorable.
That's great. Okay, but are there any complications listed? Even if the event itself isn't dangerous, are there knock-on effects from having sleep paralysis?
Well, the notes are clear that sleep paralysis itself rarely leads to direct physical complications.
Right.
However, if someone experiences it frequently, the consequences of that disruption and fear can mount up. Things like excessive daytime sleepiness and fatigue are mentioned.
Which makes sense if your sleep is constantly being disturbed or you're anxious about sleeping.
Exactly. And that, of course, can impact your overall quality of life. But perhaps the most significant point the notes make about complications is the psychological impact.
The fear aspect again.
Yes, the intense fear and distress felt during the episodes can lead to significant psychological consequences afterward. So it's important to address any resulting anxiety or sometimes even mood disorders that might develop because of these recurring, terrifying experiences.
Okay, so while the physical event isn't the danger, the psychological toll, if it's frequent and frightening, can be really substantial, and managing that becomes a key part of the overall picture.
Absolutely.
Yeah.
Addressing that fear and anxiety is crucial.
Wow. Okay, that was a really comprehensive run through. We've really unpacked these notes, I think. Gone from the basic definition into the kind of confusing mechanics of why it happens, who it affects, what it actually feels like, how it's told apart from other things, how it's managed, and the long-term outlook.
Hopefully structuring it like that, following the notes, makes it all a bit clearer and easier to, hold on to.
Definitely. Feels like we've turned dense notes into a much more connected understanding. Now, building on that really fascinating bit about the pathophysiology, the brain sort of blurring the lines between REM sleep and being awake, here's a final thought for you, our listener, to maybe chew on. Considering how sleep paralysis is fundamentally about our consciousness being online while parts of our brain and body are still functionally asleep, what does this specific strange phenomenon tell us about how distinct, or maybe how fragile, the boundaries really are between our different states of consciousness, waking, dreaming, and these weird in-between zones?
That's a great question. It certainly makes you think about how the brain defines those states, doesn't it? Really interesting point to ponder.
Indeed. And listen, if you are revising this topic or others and you're looking for more high-yield resources, do remember to check out passthemsra.com. They have some fantastic materials.
Yeah, definitely worth a look. And also, head over to freemsra.com. That's another excellent platform with great resources to help support your learning.
Absolutely. Well, that wraps up this deep dive. Thanks again for sharing the source notes that made this conversation possible. We'll catch you on the next one.